For the next panel on concerns around care post-discharge in the context of vulnerable individuals and communities, we're joined today by our moderator, Dr. Raja Samuel, who's the principal at the Madras School of Social Work. With 21 years of teaching experience at the postgraduate level, his dedication to academia and impactful research underscores his commitment to advancing social work theory and practice. So I welcome to stage Dr. Raja Samuel. I'd also like to invite up to stage our panelists, Dr. Sashidharan, professor at the University of Glasgow. Dr. Sashidharan is currently involved in several community-based mental health initiatives, most notably the Ethnicity and Mental Health Improvement Project in London, implementing new models of care embedded in local communities. I also invite Dr. Mathew Varghese, adjunct professor at St. John's Medical College, Bangalore, and at KMC Manipal. Dr. Varghese is one of the Indian co-investigators on the World Mental Health Survey of 2006 and was a principal investigator on the National Mental Health Survey of India in 2016. Welcome, Dr. Varghese. Probably getting his tea. And we also welcome Ms. Tanya Dutt, who is the secretary of AASHA, a caregiver organization formed in 1989 by caregivers of persons with mental illness. She's also the co-founder of Atmanirbhar Trust, founded in 2012, focused on creating employment solutions for individuals with mental health issues. And in this panel, we'll deeply miss Dr. Lakshmi Lingam, who's the chair professor of D.Y. Patil University School of Public Health, who was due to join us today but wasn't able to. So I'll now hand over to Dr. Raja Samuel to please start the panel. Thank you.
A very good evening to all of you. It's indeed a delight to be here to moderate this panel, particularly with very distinguished panelists we are joined by this evening. Something that continues from the last session is the thought that there was a point that was mentioned in the last panel that even when post-discharge they come back home, home is not very welcoming. There seems to be homeless within their own homes. The continuum of homelessness continues right from home to the street and so on. So that's the context in which we have the topic here today to discuss, which is concerns around care post-discharge in the context of vulnerable individuals and communities. Because the concern seems to be accentuated by the same continuing problems that are continuing there in their environment when they come back after care. So that's the context in which we are discussing, and the vulnerability seems to be continuing, and we now have to listen to the experts here joining as a panel, and I want to welcome the panel and introduce the panel to you this evening. We are joined by Dr. S. Sashidharan, who is a consultant psychiatrist based in Glasgow, UK. He has worked in multiple roles within the NHS and in academia. He was one of the first Indians to work in NHS to become the director. And he worked as a consultant psychiatrist in inner city Birmingham and was a medical director of Northern Birmingham Mental Health Trust and professor of community psychiatry at the University of Birmingham. He also held the position of honorary professor at the Institute of Health and Wellbeing at University of Glasgow. He has a long record of developing, implementing, and leading community mental health services. He is currently involved in several community-based mental health initiatives, most notably the Ethnicity and Mental Health Improvement Project in London, UK, implementing new models of care embedded in local communities. Please give a hand of welcome to Dr. Sashidharan. We're also joined by Dr. Mathew Varghese, who has been a faculty at the Department of Psychiatry in MANS for almost 35 years. He was head of the Department of Psychiatry from 2013 to 2016 and is currently head of the Geriatric Psychiatry Services and the Geriatric Clinic at NIMHANS. He was a founding member of the International 10/66 Dementia Research Group. He co-wrote and edited the Dementia India Report 2010 and Dementia India 2020. He was one of the Indian co-investigators on the World Mental Health Survey 2006 and was a principal investigator on the National Mental Health Survey of India 2016. Currently, he is a collaborator on the longitudinal aging study of India, famously known as LASSI. Warm welcome to you, sir. Give a big hand to Dr. Mathew Varghese. And we are joined by Tanya Dutt, who is the secretary of AASHA a caregiver organization formed in 1989 by caregivers of persons with mental illness. She's a co-founder of Atmanirbhar Trust, founded in 2012, focusing on creating employment solutions for individuals with mental health issues. She was awarded the Maitri Caregivers Award for families, friends of persons with schizophrenia by Schizophrenia Research Foundation in 2022, an Employees Appreciation Award by the Banyan in 2016 for providing gainful employment to persons with mental health issues. Tanya is the Executive Director of Chromatics and Insulants Private Limited, engaged in the manufacture and export of pigment dispersions for thermosets. A warm welcome to you to the panel. Okay. Right. We have very limited time in our hands, so we will plan it out very carefully. May I now request Dr. Sashidharan to go first.
I will make a few observations which I hope will act as a trigger for wider discussion and engagement. There is a health warning attached to what I'm going to say in this international audience, in this conference here in Chennai. My experience is almost entirely based in working in a very high-income country. The relevance of what I say in the global setting, in the setting here in Chennai, although some of the challenges that we face are similar, but the relevance of what I say must be considered in that context. The most relevant observation that I can make in relation to the topic that we're discussing here this afternoon is about the nature of institutional treatment and its impact on people who are treated in those institutions or through those institutions. The hypothesis that I'm proposing is that the experience of institutional care itself acts as an antibody against further treatment. It's a toxic experience that then predisposes people not to use any form of care or help. Much of the problems that we see in relation to supporting and caring for people with significant long-term disability can be traced back to the negative experiences of their initial contact and, in some cases, long-term contact with a model of care and intervention that works against their interests. This is not a criticism of people working in hospitals and within institutional settings. It is not a criticism of mental health professionals for the very hard work that they do. But it is an observation about the toxic nature of institutional care. It is not about care, fundamentally. It is not about treatment, primarily. It is about exclusion, it is about control, it is about denying individuals' rights, because that is embedded within the thinking and theories about mental illness and how to treat it. That's a legacy that we have. That's a burden that we all carry as psychiatrists, psychologists, mental health workers. Our task is to try and overcome that. Our task is to try and detoxify ourselves to some extent and to think differently. It's taken me a very long time to get into a situation where I do not think primarily as a psychiatrist. I happen to be a psychiatrist, but I have had to learn how to develop a new methodology of working with individuals who are very distressed, often very poor, who are multiply abused, who are deeply traumatized, who are excluded from society at large. And I would suggest that the best way to learn that is not by reproducing institutional discourse and thinking, but by engaging in services and initiatives that are fundamentally there to help people. The Banyan is a classic example of that. The experience of many other non-governmental sector organizations, both in the global south and in the global north, are places where you can see innovations and changes that are fundamental to addressing this problem. Similarly, the dynamic of learning from each other has to be revisited to some extent, because historically, within my profession, the dynamic has been unidirectional. Western models of treatment and care, Western models of thinking about what constitutes mental illness, have been absorbed and imported into non-Western settings. And paradigms of treatment, models of helping people, and what is a priority and what is not a priority, are also determined along that dynamic. It's important to reverse that to some extent. One of the exciting things about organizations such as the Banyan and many other NGOs that are operating in the global south largely is that there is so much of what is being done in these contexts that can be translated into high-income settings, where, in spite of the considerable funding and resources available, the mental health systems that we operate in high-income countries are very poor quality with very poor outcomes. One wouldn't expect that. In a rich country like the UK, the recovery rate in relation to serious mental illness should be at least 5 times that of what is happening in a country like India, where material disadvantages are to a larger extent addressed appropriately. You would expect social determinants of mental health to be addressed equally well. But they continue to undermine not only the health of individuals, but also the care trajectory that individuals who are most in need of help are following. I just wanted to make these observations to set out what is the issue that we're talking about when we're talking about people with long-term needs and the inability our services have for reaching out and providing them with the help that they need.
Thank you, Dr. Sashidharan. Now, he has woven a thread between the last panel and now in terms of continuing the discussion on the institutional care and its impact on the individuals and the choice and the agency that they miss sometimes are not given. But the other important question is, okay, after they are discharged, what is the situation? Is the vulnerability, is it increasing? Or how do we address that vulnerability? That is one of the important questions before the panel. So over to Professor Varghese.
Hello, check. I think the question for the panel was, what happens, what is the scenario with aftercare? And that's really the question. And I want to lean on my experiences together with Sanjeev for the last 40 years at NIMHANS. I mean, NIMHANS again is considered an institution now which is premier and premium in many ways. But it wasn't when we started off way back in the 80s. Sanjeev and I remember that NIMHANS was overcrowded. We had patients over the bed, under the bed, and everywhere. And we ourselves saw that whole transition from closed walls to open walls. That is one place I will take my experiences from. And the second place I would take my experiences from are halfway homes that I've worked with for the last 30 years or so, the Medical Pastoral Association and the Richmond Fellowship Society, which are again halfway homes, where halfway homes have slowly turned into long-term care homes because they all went in to stay for 6 months or a year, but the majority of population there in these so-called halfway homes are people who have stayed there for more than 10 or sometimes even 15 years, and they never go from there because there is no place to go to. The third situation which I take my experiences from are the group of institutions that I've been working for in the last 10 years or so, and that is the Nightingale Elder Care Facility, where they take destitutes, older people, men and women, destitutes from the streets, because they don't have anywhere to go to. They don't have families, they don't have their brothers and sisters, they don't have their children, so they're taken in. But I want to challenge this notion from the earlier panel that our families are all bad. The majority of families and patients that I've seen for 40 years and more, and even in the ones in these institutions, people have gone back to their families. And I think whether you're homeless or not is determined by, to a large extent, by your economic situation. Most of the time, if you're poor, you get homeless. I have not seen, barring, say, a handful of cases in the last 40 years, of very rich people or middle-class people who are out on the streets and not having a home. I don't think that has happened. It's happened in a few. I can remember the number of cases. But I can remember the majority of cases where people have gone back to their houses and come to us for treatment and gone back. So when you talk about what does the pathway from care look like in homeless situations, I would say that the other experience, of course, that I have is with an organization which Sanjeev and I are part of called Chittadama, where we take on people who are homeless, who are wandering around in the district of around Hunsur, beyond Mysore, in Mysore district, Shikote, yeah, and we take on those people and then look after them. This is the home that some of us are, sort of supporting. Many of them stay there, but about 25% of people who have come there in the last, say, 10 years or so, have been able to go back to their homes because they were all lost. They just walked out from their homes maybe 10 years ago or 15 years ago. And many times when they got well and they could tell us where their homes were, and we contacted their relatives through the postal system and the police system, they were actually thrilled to get them back. They thought they were dead or they thought they were not there. But they were happy to take them back. Now, if you ask, we were having a discussion over dinner yesterday saying that, has anybody done a follow-up of what happens when they go back home? A few years ago, we did such a follow-up in the Medical Pastoral Association, and we found that, again, I say it's economical because it's economics, because majority of people who we saw were people from the middle class or upper middle class. And so they were all living at home, and they were, in some cases, they were even helping their elderly mothers or fathers. So I would think that homelessness and what happens as a result when they go from homes is determined to a large extent by the economic situation. And working, as Kishore would know, in the beggars' home in Bangalore, when we were doing work in the community psychiatry unit, we obviously found that 70-80% of that population was mentally ill. There were people who were on the streets. And we had to obviously go there and provide services. So I think if it's the prisons for Europe, it's the beggars' homes and the social care or welfare organizations in the cities that are homes for the mentally ill people. So as we heard in the morning, about 5 to 10% of people who have a very severe mental illness require to stay in institutions. They just cannot go out into the open. So that's, I think, a fact that we have to recognize, and we have to recognize that there has to be these homes that have to be there has to be provisions to make for the government to make these kind of homes. And I think it's necessary for the government to sort of get their act together and get these homes. For people who go out into the community, now, if the environment is not good, if the family is not good, if the situation, the economic or other situation, they don't have jobs and so on, obviously they will go through a spiral of getting on the streets, getting in touch with the law, or actually dying because they are on the streets. So they will invariably find their way back into an institution, either a home or the prison or a beggar's home. So I think when you talk about that population, we really have to think about how can we ensure things in terms of inequity, access to treatment, access to care, access to housing, and access to just plain rights of an individual.
Thank you. You rightly pointed out the economic, one of the economic reason is one of the important criteria for the care not being available to them, sometimes either within their homes or outside, which is again a very systemic injustice in terms of poverty and homelessness is very interconnected. Poverty and mental illness is also connected. So in that context, Ms. Tanya, your work in terms of empowering persons with mental illnesses in terms of economic empowerment, can you share?
I think I would also like to give a disclaimer here that I don't work with people, homeless people. So the context for me is a little different coming from AASHA, where we run a residential rehabilitation home. And this is more for your lower middle income group. This is a caregiver organization. It's been running it was formed by families almost 34 years ago. And the whole idea was for families to have a voice in the care of the individual. So the individuals who come to us come from home and family. They stay in this residential home for some time, and they go back to home and family. So there is not much that we can do beyond a certain point of time. But yes, we do have a lot of concerns, which we communicate to the families when they are discharged. Primarily is you treat them with love and respect. Don't start making them feel like a burden on the family, because that's very common. And it's some snide remarks, or you've again come back to the family, and those sort of things we tell them not to do. We ask them to follow a proper medication protocol, therapy, doctor's visits, follow-ups, sleep, exercise. Those are the sort of things that we communicate to the families. Basically, what we really hope for is a continuity of care, because many times what happens, the individual comes to us, goes back, gets discharged, goes back to the family, and then gets flitted from different rehabilitation homes. Sometimes the individual comes back to us because the family is not able to manage. That's the most disappointing thing for us, because the individual really craves to be with the family. And when they are with us, they constantly want to be with the family. So these are some of the things that we communicate to the family when they are with us.
Okay.
I mean, it's very different from the question you asked me, but like I said, we don't deal with homelessness, so I wouldn't be able to answer that.
Okay. Not so much as homeless, but who need support in terms of their livelihood.
Yes, okay.
How do you negotiate
I can
that?
answer that. One of the initiatives that I have is Atmanirbhar Trust, where we focus on employment. And we do this by running stores. These are your basic retail stores. And we provide employment over there. These are for individuals with severe mental health issues. So that's one of the things that we have taken up on ourselves to maybe bridge the gap when it comes to economic situations, because many of the individuals who come to us are from the lower income group. And so we feel very empowered and encouraged when these individuals, they come to us, they start working, they start contributing to their family, they buy their medication, they're able to take care of themselves. So that's something that's very heartening for us.
And that's a lot empowering also. A sense of empowerment is there, when they do that, yes. Dr. Sashidharan, in terms of continuum of care, how is the scenario unfolding, which in your experience in UK, when they are discharged from the institution, and what happens next, either in homes or homeless, in both the contexts? How is it normally happens in terms of a continuum of care? What happens?
The traditional paradigm has changed significantly because the old type psychiatric institutions have become very scarce, and they are not integral to much of what happens in the field of mental health care. But as was remarked earlier on in the previous session, the institutional model has survived the closure of the institutions. Although large psychiatric hospitals are completely closed down in countries like UK and much across Europe, and to a large extent, most of the people with even severe mental health problems are managed within community settings. The institutional virus has reproduced itself in those new settings. So the model of care still relies to a large extent on the notion of treatment, and the treatment usually simplified and reduced to medical treatment, i.e. medication. The importance of social determinants, the importance of citizenship, importance of people being helped, encouraged, facilitated to make choices for themselves, and identifying the individual patient as the only person who matters, rather than taking into account the social family context of that individual. Those things have not happened. Our models continue to be the models that were developed, refined, and evaluated within institutional settings. Not surprisingly, this has meant a care pathway that premises the centrality of the institutional intervention is no longer working. We heard this morning about the major challenges they're having in the United States, where the law enforcement system, the prisons, have become the major player in mental health care. We heard also in California, the people who are trying to address that are not psychiatrists or mental health workers per se. They are the police or the equivalent of the police. It's a law enforcement agency that is undertaking crisis assessments, crisis response, dealing with people. Because the community mental health system that was meant to replace the old institutional model has come apart for a variety of reasons. And to some extent, in United Kingdom, that hasn't happened to the same degree, because we have still very well-established community mental health systems. But the individual experience of the patients or the service users and their families have not altered significantly. As I remarked earlier, the number of people who are dropping out of the service continues to increase. And the system hasn't adapted itself to try and meet them in their own terms, in their own places. So the care pathway that we imagine looks nice on paper in policies, but in actual practice, it is fragmented. People get lost within it, or people get locked into it. It's very strange. in the United Kingdom that we have a system called locked rehabilitation. That's a contradiction in terms. I mean, it's happened in the last 10, 15 years. When I started working in mental health in the UK, there was no locked rehabilitation, there was rehabilitation. Now we can see the emergence of what is called locked, the emphasis on locked rehabilitation to replacing long-term support for people, community rehabilitation. People get locked into that, and they remain locked into that rehabilitation forever. The average length of stay within those facilities is years, sometimes decades. So we talk about this natural care pathway, people coming into the service, moving on to another service, and eventually resettle in the community. Looks fine on paper, but the research evidence, experience of agencies and individuals in working in that area, and people with lived experience is completely different. It's a broken system with broken pathways. I'm sorry to sound so negative, but I only say that because we got to draw inspiration from where things are actually working and models that are making a difference, and try and introduce that to correct some of these basic pathologies that exist within our system.
Thank you. Dr. Varghese, if we have to continue the same question on the lines, what has been your experience in terms of the continuum of care post-discharge, and how do they face the vulnerabilities facing them?
I think with any chronic illness, I think the biggest challenge is compliance with treatment. And I think I would say both medical and psychosocial treatment. And that's true even for other non-communicable diseases like hypertension and diabetes. I mean, about 50% of people are not compliant on treatment. They don't take medicine. They think that they should take medicines till their sugar comes down or their BP comes down and then stop the medicines after that. So educating people and telling them that if they did not take the required medical or psychosocial treatment and did not continue it would really be very important. And there is enough evidence now to show that if people did not continue these treatments on into an indefinite period of time, they would have various complications. In the case of hypertension and diabetes, you might get kidney complications or heart complications or brain complications and so on. In the case of mental disorders, they might have caused chronic depression or chronic bipolar illness or problems with thinking and reasoning. So I think we need to underline to wherever they go to that treatment and continued psychosocial and medical treatment is absolutely required. And I think I want to underline that from what the person with lived experience talked about at the back, and we didn't hear that, and that is that having treatment makes you aware of what you can get and what you need to get, and makes you aware of your rights and makes you aware of what you need to do in terms of having things to ensure that your rights are met. I think the issue of compliance is all the more compounded by the fact that we are dealing with a mental disorder. We are not talking about all these things with regard to people who have got hypertension and diabetes, isn't it? Why are we having these laws and why are we having these discussions about homelessness? It's because the people who have mental disorders, when they are seriously ill, they are not able to take a decision about their treatment or judge about what they should do, or take a decision about whether they should go to help or not. So I think, to my mind, wherever they go, whether they go back into their families or whether they go back into other homes or whether they live in housing situations by themselves, one of the things that we have to ensure is that they get educated about long-term treatment and following up long-term treatment. I don't mean just medicine, but I mean psychosocial treatment. And that's, I think, key to aftercare.
I would agree with what Dr. Varghese was saying here, because many times individuals, the families come to us at the first point when they first come to us, or when they come back to us later on, it's because of non-compliance to medication. Somehow when the person is in an institution, they seem to have more compliance because there is a sort of regimen and protocol where everybody else is having medication. So they also do that, as well as with, with doctors' visits. When they go back to their families, somehow that drops. But being in an institution, since there's a doctor who's going to come visit every week or something, there is more chance for the individual to see the doctor.
Right. Thank you. We just have 4 minutes remaining of the session. We have to wind up by 5:30, this particular panel. So the floor is now open to questions. We can take a couple of questions on focusing on this particular topic. Yeah. There is one hand.
Hello.
I wanted to add something, if I may, about aftercare, and that is about making people aware that the community at large, which is families, legal services, police, I think it's important to make everybody aware of the provisions of the laws that we have. For example, the Mental Health Care Act. I remember discussions, and Sanjeev will remember these discussions in Nimans and other places with Mr. Sashidharan, about the government providing free treatment and medicines. And Desiraju said, "Oh, it's a big thing, because how can the government provide? It's a lot of money." But we are able to impress on him that it's indeed the job of the government to provide shelter, to provide medicines, to provide free treatment to people who cannot. So I think it's very important to make judges, police, community at large, and other people aware of what the provisions of these two laws mean, the Mental Health Care Act and the Persons with Disabilities Act. Because there are many provisions in the law which actually mandates that the community, the government, and other people take care of these people in a reasonable, rational, free manner. And that's very, 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 very important. To tell people in aftercare that this is what your right is. This is what you can get. This is what the government is supposed to provide you. And it's not as if somebody is doing you a favor. That's law. Many times, police and judges and other people in the community do not understand. And we need to advocate with them that this is the law. This is what has to be done. And there's no two ways about it.
In addition to Dr. Varghese, whatever you said, we've been doing this. We're running a program known as Dawa in Dua in a Dargah in Gujarat since 2008. And of course, I'm not a mental health professional. I am a caregiver, and I'm getting experiences in my own house, and that is what we are implementing in the Dargah, which is a non-medical setup. We have seen new and follow-up cases. We've seen more than 100,000 patients up till now, last 14 years. And what we've done is we've seen that people who come to the Dargah in search of psychiatric care, I would say supernatural phenomenons, they come and they avail treatment from us. And they've never disowned their own loved ones, point number one. Point number two, we have group discussions happening in our office with the family members and the patients once they recover. We educate them. What is the importance of the medicines? What is the importance of illness? And it has been an interactive session with the family members as well as the patients. And we have a follow-up system followed since 2008 that we call them up and we speak to the family members that how is your patient doing? In case if there's a problem, please bring them back. We have also couriered medicines to their homes so that there is continuity of care in case if they don't, have any psychiatric facility in their area. In that event, we've also sent referral letters to the areas where they've been living in. And I'm talking about all these people from the poorest of the economic strata of our country. So, see, anything is possible. I mean, for me, there is no standard model, or whatever I'm doing is not a standard model, or that is not an ideal model. What I want to do, because I'm a passive schizophrenic for living since 1994. So I can understand what is going on in my house. When I wake up, I have a schizophrenic in front of me. So I know that what those guys are going through. As a mental health professionals, probably we'll just diagnose them, counsel them and send them back home. But at 2 o'clock in the middle of the night, what happens in my home is only my story. So there are things which we've learned and we are learning even today. And we are trying to implement it so that, people say, like you walk an extra mile, there is no competition there. And at the end of the day, you need satisfaction.
Thank you. That was a great point added to the discussion.
Yeah, thank you so much for this thought-provoking session, sir. I have few reflections on the panel as well as some of the little experience in a quick manner. The question that the panel posed is the continuity of care after, whether it is homeless or homelessness. So to the greater extent, when it comes to the persons with mental illness, no need to say in this forum because the burden carried by any caregivers, still much more, the burden experienced by the caregivers. That is why a lot of new models like the caregivers themselves forming a family federation, coming out, running a center of their own, like what I think Madam Tanya is able to say. So many of the good practices, even in Tamil Nadu, as well as there in Madurai, where Chalabathu Trust is running a Subicham Family Fellowship on the same ground. But the idea is, as rightly said, for any family fellowship or family federation, the funding is the biggest problem. So a country like ours, you have to collect fees and then run the show. That is one thing. But when it comes to the continuity of care, so think about the homeless population. Who will take care of the continuity of care? The government, the NGO, or the corporate sector? Here is an example to showcase our experience is when it comes to the continuity of care. In Tamil Nadu, there is a district, Virudhunagar district, where the NGO Chalamathu Trust, almost last 15 years, a camp-based approach where we involve service organization, religious organization, and the Crackers Association of Sivakasi. They have come forward. Almost we have completed 265 camp every month. Third Sunday, we are running this camp at Virudhunagar district, and 350 patients availing. Some of them are homeless, and some do have home. They are availing the benefit of this camp, availing free medicines, and the religious institution, they are giving food on free of cost, and the government veterinaries is a community-owned model where all the welfare benefits from DDAO office they are giving, and that is the model. I think a country like ours in the future, the continuity of care to some extent will address to such issues. This is I would like to share in this platform to the panel. And
thank you for that sharing that model.
Yes, and one more thing to Danya. See, how about the success of placement? Because we do have a similar program like empowering the people with mental health issues on placement ground. We do have still miles to go when we make a dialogue with the industrialist people, corporate people, and running them, because there is one important thing what we have learned being a mental health professional in the field of mental health is when a disabled become an abled, the attitude of the family members change. So to bring that into the, say, even a person with homeless mental illness or having a mental health issues, when they become productive, definitely there is a lot of hope in the coming years. Thank you, and you can also answer for this question.
Sure.
Thank you.
I think for sure the attitude of the families will change because the families can't wait for the individual to go start working and earning money and, you know, contributing to the family. So that's one part. I have met extraordinary families. I have met very apathetic families. And I've met families who struggle so much that nothing works for them. So, I mean, that's the whole family, like I said, apathy and empathy, both of these things are existing side by side. So I think collectively we have to work to understand where the lacuna is and where we can, you know, contribute and work towards a common goal. Coming back to your question about placements, honestly, what I have seen is it's very difficult. Many of the people who we recommend, like in my, I run an industry, I have several customers and suppliers. Many of these people who I recommend individuals to, they will take them for some time, then those individuals come back. They're ready to give us donations, but they don't want to give them jobs. So that has unfortunately been my experience. So that's another reason we started Atmanirbhar, so that, you know, there was something that could be done, some sort of employment rehabilitation project that we could do.
Okay.
Right.
I'm
Just
afraid
to
we have run
add
out
on
of
to
time,
that-
but just last.
Just to
you
add
want
on
add?
to that
Okay,
question
right.
of employment is difficult, as is the experience with, say, our rehab center at Nimhans, or even with MP, Medical Pastoral Association, when they try to send them out for employment, it's difficult. But remember that as per the disabilities law, there is reservation. And if somebody is in a job, they cannot be fired from their job. They have to be given another position which is suitable for their ability. So there is a law now in place that if you are in a job, there is a reservation if you have to get a job, and then if you are in a job, you can't get fired. So there is definitely something for that.
Yeah.
Just for your earlier question about camps, I mean, I always have a quarrel with people who say that camps are still something that we should be having. I think camps are something that we should have had 30, 40 years ago. If you have a camp system, that means your public health system is not working. Why should 100, 200, 500 people come to a camp on a Sunday and fight for drugs or fight for 5 minutes or 2 minutes with the doctor? They should be able to go to the PHC or CHC and get their medicines from there. State of Tamil Nadu, state of Karnataka, state of Kerala, they have psychiatrists and mental health systems in every district. If you're having a camp, that means your public health system is not working. See, we created a system in Karnataka where Tuesday was mental health day all over the state. It might sound ideal, it may not be working, but we have to see that it works. And I think the public has to ask them, why is it not working? Why is the doctor not there? Why is the mental health team not there? We have to ask. I think that's. I would say that camp system is, if camp systems are there, that means the public health system is not working.
Thank you.
Yeah.
We'll take one last question.
Yeah. So,
Okay.
no, about talking about continuity of care, the therapeutic relationship that we have with our client is extremely important. And that's why I agree with Dr. Sashidharan that when their initial experience in a psychiatric hospital is so negative, how do we develop a trusting relationship? I had to get up and speak because we were talking about treatment compliance. We don't even use that word in our treatment setting. We talk about treatment concordance, right? Even the word compliance is so coercive, so toxic, right? Now, I have to go to the dentist very often. I hate going there. He's a good guy. But because of the negative experiences, even when I know I have to go, I try to avoid as much as possible, try to delay as much as possible, right? So if we talk about continuity of care, we want our clients to come back. It's a long-standing relationship, which should be underpinned by respect, by trust, and of course there will be failures, right? And so this total focus on symptom reduction, and if they just listen to us and take the medicine, everybody will be fine, is not going to work. That's not the way to build relationships. I think it's very important that we focus on these issues. Sorry about it.
Can we have your... Please go.
I just had one comment on. Am I audible? I just had one comment on continuity of care. So I work in an organization in Mumbai which works with violent survivor and homeless young women. And mental health is also one of our target areas and intervention areas where we do intervention. We have seen individuals who live with us for 6 months, 9 months, and they are on medication. Their symptoms have reduced, and they are doing very well. They are able to sustain a job. They are able to earn a living. But the moment they go out and or they are moved to another shelter home, or they move out to live independently, the access to medication reduced, and or the other shelter homes are not as cooperative as they do not have mental health interventions in place, and their symptoms again resurface. They lose their job, and they again fall back into the same circle and same loop, and they again come back to us. Because they again go homeless, and they again come get in touch with us through any medium, our outreach stream or any other referral system. So we are just, this is a constant challenge that we face, that individuals with mental illness, even though they are continuing care and they have systems in place, they again fall into the same loop of homelessness and mental health issues, and they never seem to get out of it. So organizations like Banyan do help in terms of long-term rehabilitation, but because of absence of these organizations in state like Maharashtra, it becomes very, very difficult to rehabilitate these individuals with mental health issues, homelessness, gender-based violence, because this family system is also not in place. So it's not like we can fall back on any other system apart from the institutions that are in place. We face the same issue for employment also. So I wanted to ask if you have any insights on those. Because 2 months they are able to sustain the employment and they are back to square one again because their symptoms resurface, or we don't have employers who have an awareness or sensitization towards mental health related concerns. So this is a constant challenge that we face. So just wanted to.
You want to take that before answering? I want to. Go ahead.
Yeah, I think what we have noticed in Atmanirbhar, it's now 10 years since we've been running this. We run 3 stores. We have about 16 individuals working with us. What we have realized in this, we have noticed is, it doesn't matter like the qualification of the person, the capacity of that person at that point of time, the work, when they come to us, we just put them in the job of whatever they are able to do at that point of time. And we slowly, build up the challenges, and slowly they start improving. And what we have noticed is, because there is no pressure on them, to perform or do, achieve targets or all those sort of things, they improve, their abilities start improving. And once we notice that, you cross the threshold of maybe 2 months or 3 months, they are able to sustain. We have individuals who are with us for the last 10 years. So we have noticed that people are able to sustain, people are able to work. You just have to take the pressure off them.
Thank you. We'll take, Dr. Jain, go ahead. Yes.
So it's very important that we have continuity of care. It's equally important that we have continuity of the care provider. By labeling most psychiatric training as being toxic or pathological or inherently coercive, what you're seeing is a flight of psychiatrists from the profession. Number of residents opting for psychiatry is lesser in the West. In the UK, there are many positions lying empty, because this atmosphere that psychiatry is, by its very essence, manipulative, coercive, underhand degree and a profession, really puts off people. And doctors do not want to be seen as the villains of a service. Therefore, the interest in maintaining psychiatrists in the long-term care is very, very critical. You cannot demean or call the entire edifice of psychiatry as being pathological, institutionalized, toxic, kind of miasmic horror story. That really drives the essential linchpin of the service away from the service. And that would be really a loss.
I just have a quick point to make. So we had 2 cohorts that we followed over a period of time. I would think from 2010 all the way up to 2020. that is a group of homeless people with mental health issues. And when we retrospectively, actually we didn't follow them systematically, but when we retrospectively looked at how many of them were doing well and why, we figured that it was a very small percentage. So at that point, it was about 17%, and then it jumped slowly to 42%. And then now, over the past 3 years, we've sort of followed people prospectively and figured that those numbers have jumped from 17 to 42 to now 72% in terms of engagement with service. And what's helped is a combination of what Dr. Ganeshan Maheshan said, care commitment, Sanjeev said, the care team and a consistent care team, what Dave said in the morning about building trust. So I think when there is trust with the care team, when there is a consistent care team, and when care is about medication and beyond, and that beyond matters hugely in the case of homeless people with mental health issues, and includes what our friends, Mr. Babu from Chelamuthu Trust mentioned, that is PDS, access to the food distribution system, because for homeless people, these are problems that run into bureaucratic tangles. And therefore, facilitating some of this and ensuring that they have access to PDS and food distribution and food, access to the disability allowance or a basic income or out-of-wage sort of scheme, and access to conflict resolution or problem solving when there is a sudden emergency, so sort of a crisis, a situation of crisis. So I think the combination of sort of being there through some of these complex problems, but also facilitating sources to address social determinants and improve social capital, and of course also initiate the process of livelihoods facilitation. So essentially work with the unit and with a consistent care team and ensure that there is enhancement of income and facilitation of community inclusion, but also work towards a valued social role. So I think that combination that we sort of placed in the matrix and then followed through over a 3-year period has brought us to this 72%. But it is a struggle and it is a consistent care team.
Yes,
Thank you. We are going to conclude this session. I think one more. We can take one more.
Tiruchelvi has a
right.
question.
So,
and from
comment
Dr.
here and a
Mazzinas.
question there.
Tiruchelvi,
Yeah, with that.
please. Her mic, can someone help her with the mic, please? Thank you.
எல்லோருக்கும் வணக்கம். மேடம் வந்து சொன்னாங்க, அதாவது கேர்கிவர் பக்கமும் எம்ப்ளாய்மெண்ட்டுக்காகவும் ஒர்க் பண்ணுறோம், அது ஹோம்லெஸ்லேருந்து நல்லானவங்களுக்கு அப்படின்னு சொன்னாங்க. எனக்கு ஒரு கேள்வி, சில ஃபேமிலியை வந்து ஏற்றுக்கிறாங்க, சில ஃபேமிலிஸ் வந்து அவங்கள வந்து அக்செப்ட் பண்ணிக்கிறது இல்லை அப்படின்னு சொன்னாங்க. அவங்க எவ்வளோ ஃபேமிலியை வந்து நல்லாக்கி வீட்டுக்கு போனப்போ அக்செப்ட் பண்ணிக்கிட்டாங்க, எவ்வளோ அக்செப்ட் பண்ணிக்கல, ஏன் வந்து அப்படி அக்செப்ட் பண்ணிக்காமல் அவங்க நல்லாயிட்டாங்க, அவங்கள வந்து அக்செப்ட் பண்ணிக்கலாம் தானே, ஏன் வந்து அந்த ஃபேமிலிஸ் வந்து அக்செப்ட் பண்ணிக்க மாட்டேங்கிறாங்க அப்படின்னு ஏதாவது வந்து ரிசர்ச் பண்ணி ஏதாவது வந்து இருக்குதா?
The reasons for families not accepting, yeah.
Yeah, can we have a translation of the question though before?
Yeah, sure.
Sir, if you can. Thank you.
What the question raised was, some families are accepting after treatment, but some families are not. What are the reasons why families are not accepting the person with mental illness back?
Did she say they're accepting after being employed?
No, not generally also.
No,
Generally.
in general. Okay. I think, like I said, I've seen some extraordinary families who go an extra mile for their family member, and there's some families who are very apathetic. What I have seen is, until the parents are alive, until the parents are there, there is care. Once the siblings come and the siblings have their own families, that care seems to go. So basically, and families have their own expectations. They have expectations with, they don't want to go that extra mile to take care of the person. You know, they look at the person as a burden. I really hate to use the word, but that's what's been happening. That's what I've seen at AASHA. We have a constant struggle with families. Like I said, I have seen some extraordinary families, including my own, who have gone that extra mile, but this tussle that goes on with the families is, I really don't know like how to address this beyond pleading with the family. Actually, ours is, as you know, ours is a halfway home, but we have individuals living with us for the last 15 years because the family doesn't want to take them back. And the option is, if we say, no, you have to take them, we are a halfway home, they will go to some other rehabilitation home. At that time, we are like, no, that's fine, they can be with us. We know at least they're being cared for under us. So I don't know whether that's an answer.
ஒரு 2-3 காரணங்களை அவங்க சொன்னாங்க உங்களுக்கு. You're already translating.
இல்ல study பண்ணிருக்கேன். Tirchilvi also wanted to know whether you have done any studies on why families don't accept. Have you done a research or any kind of, that's what also she wanted to know.
We haven't, but I'm sure there could be other organizations who have undertaken this.
Dr.
Okay.
Messina.
No, just would like to say, to emphasize that we are somehow agreeing on the idea that continuity of care is one of the key issues, and this is based on therapeutic relationship that must be based on trust, as Dr. Ganesan said before, and also an idea of going beyond the strict medical model, so integrating into a comprehensive offer of care. And sometimes we heard also that these other elements are even more important than treating people from a psychiatric perspective, strictly defined. So well, I would like just to add that maybe this is a reflection of what we have done in some places where long-term institutions have gone, is that the model of the so-called linear continuum for rehabilitation has been put into question. So because it doesn't have a real evidence base. This was pushed by many eminent psychiatrists. Let's think in Europe, Luc Ciampi, for instance, thinking that there is a progression on the axis of housing, for instance, from more for support and sheltered places to more, and also in the axis of employment, work, etc., etc. But this is not reflected by the practice. When you work in the community, you realize that this comprehensive care can float, and you can offer opportunities to some people which are so-called uncompensated from a psychiatric point of view, but this kind of offer works to engage people in an overall comprehensive view of the offer of care. And sometimes the treatment can come afterwards. So, for instance, I have remember at least a couple of people working in an agricultural cooperative. They refused to take medication. They were very difficult to engage, but they accepted to be integrated as members of the cooperative, and they started to work in fields, etc., with small group of people, small teams, and they enjoyed that, and they improved the quality of life. And then, after even months or years, they accepted some kind of treatment. So, but this kind of offers can be played at the right time according to what are the people's expectations about their whole life, not just in a progress for rehabilitation. Rehabilitation is mostly today offering opportunities and enhancing the capabilities of people to access those opportunities, and this doesn't happen in a continuum. As the process of recovery we know is done like this, like ups and downs and plateaus, etc., etc. So we should accept to navigate a little bit more in the open, because we don't have so many evidence to support the old ideas of rehabilitation.
Thank you.
Thank you, Roberto.
We'll have to
stop
now because of the time. I think this session offers a lot of hope. Post-discharge, there is home. But if not home, there is home again. And if not that, there are other things. And of course, strongly supported by the entitlements that comes from the law. I think with this, I appreciate the panelists for their interventions, and also for the audience for their comments and questions. Thank you.
Thank you very much, everyone. Really appreciate it. Thank you, Dr. Samuel.